So thanks very much. I have many of you in the audience, the distant audience, I know because I live in Graham-Bruce and continue to live in Graham-Bruce, but am now privileged to have the opportunity to work with the Southwest LHIN and as well as the Southwest CCAC to actually put into action the Access to Care project that is looking at seniors and adults with complex needs across the Southwest LHIN.
And I, Mr. Chair, I keep an eye on Sue because I look across the valley and I see her house.
You can see my house and I can see his farm. So just a few things that I wanted to accomplish today in this presentation was to actually talk a little bit about why this particular project is important to the residents of the Southwest LHIN. It is a project that got up and running in the fall. I joined in January, but certainly the staff that are working on this project have started to see some really good gains, and I want to share those with you. And of course, when I have the opportunity to talk to governors, I think as we move this project forward and the changes that are happening across the LHIN and will be happening across the LHIN to support this project, we will need to involve governors in those discussions over time. And so I would bow to your wisdom on how to do that. So just to speak to the importance of the Access to Care project, we really do know from the research, and it's fairly robust research now, that seniors and adults with complex needs who end up staying in hospital after their medical crisis has been resolved. It may not mean that they can, you know, in the days that we would say that they could go home, but when they stay in hospital, they're actually having two things happen to them. Their functional, or their ability to function, so that's the activities of daily living, those things decrease, so their ability to get around, in and out of chairs, often on toilets, those things does decline, as well as their cognition. And so if they're having any issues with confusion or dementia, those actually get exacerbated when they stay in hospital longer. And so the other piece, of course, with this particular audience is this project is very clearly designed to be well aligned with the blueprint, the Vision 2022, that this board has certainly supported. I had the chance to be part of that work early on, and this is well aligned, and it is a key part of the current Integrated Health Services Plan for the Southwest LHIN. So we know that we're not perfect, and so these are a few of the areas that we're hopeful that this project will help improve across the Southwest LHIN. And so we do know with the elderly and the actual performance report for the Southwest LHIN, the ER visits that could be managed elsewhere for the age group between 65 and 74 could be improved. So those are the ways that we could actually take care of those people differently and not in the emergency room. We do know that we have a percentage of patients in acute care that could be better cared for in an alternate care setting. And so there's a huge cadre of where those people could be cared for, but we do know that the percentage is higher than we want it to be. And the other piece is that the actual length of time that people are spending in hospital in this designation of needing an alternate level of care is fairly high. And so I just pulled this morning a couple of them. LHSC, or the London Health Sciences Centre in London, is in the sort of 65 to 75 day range on average for patients who stay. So this is after their medical crisis is done. And in St. Thomas, which is the other place we're beginning to do work, that's sitting around 50 days. So it is a fairly long time that these people are having to stay in hospital after their medical crisis. So we often get into these kinds of complex, big problems and say, is there any way we can fix this? Is there any way that we can make a difference? And so what is cited here on this slide is some of the work that's actually been done within this LHIN to really take a look at what is it that we could do differently that would improve care for these people. And so I list a bunch of those different projects, but in essence, it's really about intensive case management, and that is really helping these individuals and their families who have very complex needs to actually wind their way through our fairly complex healthcare system. And so that's really to have somebody who helps navigate the system for them. If you can just get a little bit of personal and homemaking service in the home, it can sometimes make all the difference. Medication reconciliation and management. We're learning more and more about this all the time. All that means is that when you're discharged from hospital with a certain list of medications and you start the next day or that evening to take those medications when you get home, that they're actually the medications that you were ordered to take. So when you get home, you often have a whole bunch of medications in your cupboard, you may have some in your purse or sitting on the counter, and it's to make sure that there's a complete alignment with the medications that are ordered and the medications that you're taking, and figuring out a system to help make sure that people are doing that. The sooner we think about helping you get home, the easier it is to help you get home, and that we know for sure that it takes really strong linkages across the system in order to support these people. And I think this last point is probably one of the most important from my perspective, is that we work with people rather than caring for people. And so that piece of empowering patients, working with families to actually design the care to work for them. So overall, just to tell you a little bit about the team, I have the privilege of being able to lead a team, but we have co-leads for a bunch of different smaller projects, and they're all really hardworking and engaged. We've got some really skilled leaders that we've been able to second into positions, and we're really well positioned to actually make the changes that we're hoping to make across the LHIN. Just wanted to sort of stop and tell you a little bit about this woman. Her name, and she's agreed to have her first name used, and stay tuned. We've got a 4.5-minute video that Teresa in the background there has been helping us do, and so Katherine's allowed us to video her in her home. But she was very active, living on her own. She is in her 80s, and she was admitted to the hospital after a fall. This is a woman who fell after dinner time one evening in her kitchen, found by her neighbor 24 hours later, unable to get up, and had suffered significant nerve damage to her right arm during that period of time. She was in hospital for almost 3 months. She did say that during that period of time she'd given up. She was thinking there's no way, her arm wasn't working, she wasn't getting around the way she used to, that she was going to end up going to long-term care. And she said she didn't want to go there, but she didn't think that there was any other opportunity for her. She worked with the case manager. She did go home on an intensive care plan at home. So she had a personal support worker in the home for 3 weeks, 24 hours a day to help support her and get things set up. She is now at home learning how to paint again. Those are her paintings that you see on the wall. And she is just living with assisted living at home, and that's it, and has no plans to go anywhere else unless absolutely necessary. So she tells a very compelling story. So that was one of the portions of this particular project, but we've got 2 pieces that we haven't really started to see results yet. We're working on the planning stage. And I'm going to stop and explain these awful acronyms that are across the top here. CCC stands for Complex Continuing Care. And these are patients who are medically complex, who do need hospitalization, but are usually there for about 3 months. And we do intend for them to be able to go home, or at least to a long-term care facility. Just as an example, one of the types of patients that might be in this category are somebody who require a ventilator to continue to breathe, and we do expect for those people to be able to go home, but it takes a little bit longer to get stabilized and ready. The rehabilitation, I think that's a more commonly known term. And ALS-HADP, it's taken me 2 months to be able to say that without stumbling over it. But that's assisted living, supportive housing, and adult day programs. And assisted living and supportive housing are really around supporting with personal and homemaking in the home, and adult day programs are ones where people go, who live at home, but go to a day program anywhere from 1 to 5 days a week in a social setting, get some meals and do some really interesting things. So those are the other parts of this project. And I've got teams that are working on both aspects of those. They are going to be bringing forward recommendations in the next few weeks. One recommendation will be on where in the Southwest LHIN should these programs be. They are in certain places across the LHIN, but we know that there are gaps in the geography, and so they will be making suggestions on potentially moving some of those. And when I talk about that, I know that that's challenging to think through, and so we've done a lot of work on data to make sure that we're making appropriate recommendations there. We're also looking at how best to put the legislated expanded role for Community Care Access Center. So this is, right now, anybody who's admitted into a long-term care facility goes through a process with a CCAC case manager in order to be admitted to long-term care. The same process will happen for complex continuing care beds, rehabilitation beds, assisted living, supported housing, and adult day programs. And so over the next year to maybe year and a half, but mostly over the next year, we will be implementing that change in process. And so the recommendations will be coming forward about how that happens, where we go first, all of those kinds of things. We've had lots of really good discussions with hospitals and different parts of the community sector over the last number of months. I've had the privilege to be involved in the last couple of months. And when we talk about the change in admission processes, we had the opportunity, Woodstock General Hospital has opened some new rehabilitation beds in the last little while. And so those beds are early adopters. So we've got a CCAC case manager who's actually now managing the admissions into those rehabilitation beds. We're 3 weeks into that. It's a little early, but and I think we've got 7 new patients that have gone through the process. So we're going to learn a lot from that. Both teams are on target for recommendations. This says March the 31st. We're going to be okay with one team. We're going to be a couple of weeks behind with the other team, so, but we're getting there. The third aspect of this is really about Katherine that I talked about earlier. We started this home first philosophy work in London and St. Thomas. So the University Hospital has started this back in the late fall, and we're starting to see good results there. We started also at Victoria Hospital in London and in St. Thomas in January. The St. Thomas team, being a slightly smaller hospital, has just kind of hit the ground running, and they're making change more quickly than Victoria, but that's understandable with its larger, more complex piece. And both Tillsonburg and Owen Sound are, I'll say, chomping at the bit. And there was a bit of a competition as to who was going first, and we're going to be able to work with both of them in the fall to move that forward. In London, these particular pieces of information are in London. We are seeing overall referrals to CCAC to help get these people home. Those are increasing. And actually this point is at the end of January, and that's true, but also at the end of February, we've now got some statistics to say that we are continuing to move people home with these intensive care plans, and they are being successful at staying home. We're seeing referrals to CCAC on the day of discharge decreasing, and also the numbers of patients that are designated as ALC for long-term care is dropping. And just in the last 6 weeks, we're also seeing those alternate level of care patients also decreasing at University Hospitals. So we've been a little nervous about waiting on how long that might be, but in February and early March, we are actually seeing those overall ALC numbers coming down, which was one of the system changes that the project wants to see. The flow of information around patients and patients who move through the system is always a question that is important to ask. And so part of this project is working on moving that information electronically rather than by paper and fax, which we currently do a lot of in the healthcare system. So for instance, for Katherine, the people who are thinking about or being planned to go home on those intensive in-hospital home care plans, we are actually looking at a way to screen those as they come into hospital and get an electronic referral through the CCAC. We will be testing that electronically in about 3 weeks in LHSC. We've got the screening tool all tested and we're ready to go, so we're excited about that. We're also going to be doing some work at St. Thomas from the inpatient unit and getting those electronic referrals. We're also looking about how to manage those admissions into complex continuing care and rehab and managing that electronically. We've also got a system, and it will go live in June, but it's a system where every patient who comes to the hospital, and when they register at the hospital, their information will be tested against the CCAC information, and that will notify the caregivers on both sides if that person is already a CCAC client. And so what that means is that hospital staff know that they're a CCAC client, and the CCAC knows that that person that they've been caring for a fairly long period of time has had to go to the emergency department for some reason. And so that means that they can plan together more quickly. And we're also looking at doing some work around understanding capacity in those adult day programs, supportive housing and assisted living. Because right now the case manager, if you want to admit somebody to an adult day program, it's phone calls to several different places or faxes to several different places, and this would be an electronic way to say we've got 2 spaces in Southampton. Yes, Jeff?
Just a question, so does this tie back in with the family doctor as well?
That's going to be in the next piece. This one doesn't at this point in time, but the Spire project that you guys were talking about earlier, which does link the family physician to that, we are looking at also linking CCAC into that so that all 3 parties will be, that information will be known to all 3 parties. So that is in the plans. So next year, we've got all these reports that are coming forward around recommendations. So we want to spend the first 3 months of this year really doing some stakeholder engagement and really understanding those recommendations and how we get them to a viable and feasible implementation report. So that's the key thing, and I know Kelly's going to talk to you a little bit about making that happen. And we will be, as I said earlier, moving that home first philosophy and giving the opportunity for intensive hospital to home care plans for people both in Tillsonburg and Owenstown. So this is complex change, and how do you actually make that work? And so what I've learned in my short time is that it's about doing a lot of talking, surely, but a lot of talking by a lot of people to get to true collaboration. And it is based on a core understanding that we can make a difference. And once we as different sectors in the healthcare system get to that point, we can actually work really well together to make that difference. It does require all of us to change and to think, and at the very crux of it is to think about elderly patients differently than we do today sometimes. And it does require, we may not have all the right services in the right places at this point in time, and it will require us moving resources from one organization to another. So just a couple of slides on the role of governors. As soon as we talk about shifting resources, it does mean integration. And so there will be a need for governors across the system to lead discussions on integration and to facilitate the discussion and the decision making. And I think we need to talk about at some point in time, not necessarily today, but if we only promote integration on a voluntary basis, or do we look at it on a facilitated basis? And I know that's a very different process, but it may be one that we want to think about as time goes on. And I know that I've initiated through some of the work with the hospital CEOs and with some of the community support agencies to actually get information and briefing notes out. So we did send a briefing note to all the hospital CEOs across the Southwest LHIN in late February for them to work with their boards and share with their boards. We've more recently sent a similar one to the community support agencies for them to do the same thing. And we are starting as a project to engage the health service provider boards on an individual basis. And in late February, I had the opportunity to speak with the Tillsonburg Board of Directors. We're targeted to go to the St. Thomas Board of Directors, the hospital, in May. And we're just in negotiations with Listowel and Wingham as to a time to go to them. And that's on an invitation basis. We put the same invitation out to the community support agencies. I know that you as a Southwest LHIN Board of Directors also have a board-to-board reference group, and so I put that just on the table as an opportunity potentially to begin some of this discussion, and very open to any other strategies that you might have I also know, just in discussing with staff, that the plans for the integrated health service plan are underway as well, and so having this project and some of the work of the project integrated into the integrated health services plan would be another suggestion from me. And with that, I'll be quiet and ask if there's any questions or comments.
Any questions, Sue? Linda?
So thanks, Sue, for the presentation. It looks like you're moving quite a ways down from where I remember the beginning. Yes, yes. Sounds good. Feedback coming back from communities, and I'm going to ask, is there any sort of feedback coming at this time? Are you monitoring it? And would you be providing us with, I'm not looking for all of the information, but a bit of an overview from communities? I'm thinking in particular those more remote areas that's more difficult to serve and some issues.
So at this point in time, particularly with the home first clients that are going home in this intensive hospital to home work, we're doing it by a case-by-case basis and getting a lot of feedback from family and the community within which they live. We started out in the urban areas, so in London and in St. Thomas. And so until we perfected the process a little bit. So as of March the 1st, we are actually fully out and about in all of Middlesex County and Elgin County. So part of it is to say we haven't quite got there to be able to get feedback, direct feedback on those particular cases. We are building that feedback, that community feedback though, into our stakeholder engagement that we're looking at for those recommendations coming forward. So don't have an answer for you today, but know that we would be seeking that and would certainly bring it back.
That's good. I'm pleased to hear that. I think it's important for this board to know as we walk through this. We talked about that dominoes effect earlier, and you know, there's always an opportunity for us to pause, take a look, and see whether we need some adjustments along the way. My second question, if I may, Chair, was through the IT area. You've got a number of partners that you've identified that need to be sharing information. I'm a big fan of the IT thing. I think it's really going to take us miles. I didn't hear you talk about confidentiality of some of this and the sharing of information. I know the tools are there. I'm just, I also know that the older generation worries about that a lot. So I'm just asking for your assurance somewhere in this presentation, I didn't see it, but that you're thinking about those confidentiality issues.
Absolutely. All of the electronic notification, electronic referral would either be within the circle of care, so those that are already consenting to get information about that particular patient, or it would be in absolutely secure, so for instance, the Health Portal Gateway, or Health Partner Gateway portal is set up for us to be able to share information amongst organizations that have the ability to have that information. In other words, the patient or client has consented to that, and there is a secure way for that information to be transferred. So, yes.
That's good. That's good to hear. I know that it was raised as a concern, and I'm trying to think of where we were, and I think we were close to it. Oh, it's a comment, but it's not for sure. We talked about the off hours, the after hours, a lot of seniors being discharged on weekends, and then that sharing of information. And there seemed to be a bit of a gap there as to getting right meds on a weekend and that kind of thing, but the sharing of information all came through. So I'm just passing that on. That was a concern, and I haven't seen it addressed there, but hopefully when we're back talking with our folks from IT, the security issue and the after hours weekend issue is addressed there, and that sharing of information and the correctness of, I think actually we were up near your area. I think we were in Tobermory and people were saying pharmacies were closed.
Yes.
And sharing, and we were hearing that quite often. So
it is one of the things that we're aware of, that things run differently at 2 o'clock in the morning on Friday night than we do at 2 o'clock in the afternoon on Tuesday. And so building into the processes, we need to understand what it is that we have available at those times and make sure the process works both those times. Yeah.
So good. So when it comes back, I'd like to see something on those safety issues and certainly the sharing of information. So the feedback is shared with this board, not in great detail, but at least we have a snapshot of how things are going along.
Great.
Thank
Happy
you,
to do
Sue.
that.
Ron, you had a question?
Sue, under stakeholder engagement, our briefing notes that went out to the hospital CEOs and other community agencies, how do we follow up on that to make sure that we're on their agenda and they have us in their headlights with all the other things that they're working on?
I know from the hospital CEO piece, we are going back to talk to them on April the 13th at their gathering meeting, so that we will be able to get a sense of whether, you know, I heard automatically that it was helpful, that the information was helpful, but I haven't heard yet how they're actually using it and what more information they need. So April the 13th, we are meeting with them and we'll be getting that information. I'm working with, I don't know the community sector group as well, and they're a larger group. And so I'm working with a small group of people to figure out how we best get that information back from that particular group of organizations. And so I think it's the 16th of April that we're actually talking with one of those networks to see how best we, you know, make sure we get that feedback loop happening.
Great stuff. I think we've made huge steps from what I can see some of my neighbors that have participated in the, and didn't go to the long-term care facility like everybody thought they were going to. I think it's stakeholder engagement. I don't hear much in this about the primary care physician. Are they involved in this, or should they be involved more? Or if we need them involved more, how do we get them involved more?
It's a great question. At this point in time, we're involving the primary care physicians, the hospitalists, the specialists in the hospitals in which we are actually doing the work. And so we've got lots of quotes from physicians about how that's changing their practice and how they're able to care for patients in those particular hospitals. What we need to do is actually, we've got it on our to-do list, is to talk to Rob Annis, who's the primary care physician for the Southwest LHIN, to talk about how we best hook into the primary care network, primary physicians across the LHIN, so that I know that it'll be most important when it actually hits their patients and the patients that they are caring for. But it's also helpful to have some of that information about what's changing in the system ahead of time. And so we're going to try and rely on Rob a wee bit.
And maybe just add to Sue's comments that some of the board members that attended our fall OMA sessions may remember we actually started some dialogue with primary care at that time around access to care and health first.
I went to one of those.
And we got really good input and dialogue going at that time. But as Sue said, we need to look back now through Dr. Rob Annis and continue with that engagement strategy with primary care.
Any other questions for Sue? Jerry?
Through you, Mr. Chair. With regards to assisted living and supportive housing and ADD,
Adult day
adult day
programs,
programs, you're talking about trying to decide where they would be best located and make recommendations in that regard. And I think I can see that working for assisted living and adult day programs, but with regards to supportive housing, that involves bricks and mortar. And I'm curious about what you're thinking in terms of suggesting locations within the LHIN in regard to supportive housing.
Bricks and mortar are, as you know, it doesn't matter what you're talking about building these days, bricks and mortar and changing bricks and mortar is a challenge. And so I will tell you that we're approaching our recommendations from two fronts. One is to honor the data and where people in need are, but also counteracting that against where the bricks and mortar are. And so are there other ways that we can get the service where it needs to be without having to build new bricks and mortar or move or that kind of thing. So I don't have a perfect answer for that, but just to say that we're taking that capital piece into consideration as we're putting our recommendations together.
So you may have mentioned it, if you did, I apologize. Are we measuring at all readmissions? Is there any relationship?
It's not in this presentation, but absolutely. There's two things that aren't in this presentation that we are measuring. Readmissions is one, both readmissions into hospital and readmissions into the emergency department, or excuse me, emergency visits. The other thing that we're measuring is the acuity or the level of needs that people have in these different programs. So we are anticipating that the level of needs that we see in long-term care and in community programs will be higher as a result of this work. So those are two measurements that I didn't talk about.
And that'll be reported somewhere, or
Yes, it will, once we get it all set up.
we're pushing?
Yeah, good, excellent.
Just maybe add to on the question of readmissions, I think it's a good question. Sue talked at the beginning of her presentation about some of the key elements that have been built into the change process around Home First, so medication reconciliation, intensive case management. So we had the opportunity through the High Risk Seniors Project, which this board funded, to test those changes to the system. And one of the indicators that we watched at that point was readmission rate. And we had Walter Wilchess from UOT leading our evaluation on the High Risk Seniors Project. And we did, although we couldn't claim statistical significance because our sample size at the time wasn't large enough, we did definitely see a trend in reduced readmission rates against those that were expected in that seniors population that we were targeting. So we've been sort of held up as an example in the province with that transition work in the Southwest. So it's just, I think, important for the board to be aware of that, and that it has very much informed, as Sue said at the beginning of her presentation, the implementation of this work here in the Southwest.
Well, thank you very much, Sue. That was